For those of you who are not familiar with me, I'm Misty Humphreys. I'm from UC Davis in California, and I'm joined today by Dr. Manuel Garcia Toca, who is a physician at Stanford University. So it's all California this afternoon. We're happy to be here, and I'll turn it over to him to introduce the first session.
Thank you, Dr. Humphreys. Good afternoon, everyone. Our first speaker today is going to be Dr. Tanner Kim, representing his group, and the title of his talk is Long-Term Durability of Superficial Vein AV Fistula for Dialysis Access.
My name is Tanner Kim, and I will be presenting our project entitled Long-Term Outcomes of Transposed Femoral Vein Arteriovenous Fistula for Abandoned Upper Extremity Dialysis Access. We have no disclosures. Autogenous upper extremity arteriovenous fistula are the preferred mode of access for hemodialysis per KDOQI guidelines, and numerous studies due to high rates of patency and lower rates of infection compared to grafts or access sites in other areas of the body. However, there is a rapidly increasing number of patients with end-stage renal disease on dialysis, and their longevity continues to increase. This has led to an increase in the number of patients with challenging access due to multiple failed upper extremity access sites or severe central venous stenosis. Alternative options for dialysis access include hybrid catheters and grafts, as well as lower extremity arteriovenous fistula and grafts. Hybrid options are limited by patency, while lower extremity grafts have high rates of infection. Lower extremity arteriovenous fistula, such as the transposed femoral vein fistula, have been shown to have high rates of patency and low rates of infection compared to grafts. However, data regarding long-term outcomes are limited. Thus, the aim of this study was to characterize the long-term outcomes of transposed femoral vein arteriovenous fistula. We conducted a multi-center retrospective review of patients undergoing transposed femoral vein fistula from 2000 through 2018. We record demographic and comorbid data, medications, procedural information, and perioperative and long-term outcomes. Patients were deemed suitable for transposed femoral vein fistula if they had exhausted their upper extremity access or were unfit for upper extremity access due to reasons such as severe central venous stenosis. Patients were required to have palpable pedal pulses or triphasic waveforms by Doppler. Patients were also excluded if they had lower extremity wounds, and the preoperative workup for patients being considered for femoral vein fistula included an ABI with a value greater than 0.7 with normal waveforms, as well as a venous duplex ultrasound to rule out DVT or vein wall thickening. All procedures were performed under general anesthesia, and patients were systemically heparinized during the procedure. The femoral vein was exposed via longitudinal incision medial to the sartorius. The femoral vein was mobilized from the junction of the profunda vein to the proximal popliteal vein. The distal SFA, around the level of the adductor canal, was dissected free. The vein was then tunneled subcutaneously in a fashion similar to a basilic vein transposition, as shown in the slide. An enticide anastomosis was then performed. If there was a size mismatch, the vein was tapered to create a 4 mm anastomosis. The wound was then closed in layers and a drain was placed. Shown are the characteristics of patients who underwent a transposed femoral vein fistula. There are 21 patients in total. The mean age was 53 years old, and 47% of patients had a history of diabetes. The mean number of prior access sites were 5.3, and the mean time on dialysis was 6.1 years. Shown are the post-operative outcomes. Patients were resumed on anticoagulation if indicated based on preoperative medications. There are 4 post-operative DVTs. None of these involved the profunda vein, and all patients were able to maintain their access. 2 patients developed compartment syndrome. In 1 patient, this occurred in conjunction with a post-operative DVT. Both patients required urgent fasciotomies, although both were able to maintain their access sites and were ultimately used for dialysis. 5 patients developed wound complications. 2 patients required operative debridement, although all were able to maintain their access. Notably, there was 1 mortality at 18 days, although this was unrelated to the index procedure. The patient developed an SBO with a subsequent cardiac event. 1 patient developed Steele syndrome with symptoms of breast pain on follow-up. This patient underwent a femoral to above-knee popliteal bypass with PTFE, which was performed in a similar fashion to a drill procedure. The SFA was ligated distal to the fiscal anastomosis site. There are 5 patients who required adjunctive endovascular procedures to maintain fistula patency. 1 patient developed progressive calciphylaxis requiring a BKA at 18 months post-procedure despite undergoing extensive workup, including an angiogram, which demonstrated adequate perfusion. Fortunately, they were able to maintain their access even after the amputation. Shown are the primary and primary cystic patencies. The mean follow-up time was 34.7 months. The primary patency at 1, 3, and 5 years was 93%, 74%, and 74% respectively. The primary cystic patency at 1, 3, and 5 years was 100%, 89%, and 89% respectively. Secondary patency at 1, 3, and 5 years was 100%, 89%, and 89% respectively. Overall survival at 1, 3, and 5 years was 80%, 50%, and 50%. In summary, transposed femoral fistula for dialysis access is a viable alternative for patients who have exhausted their upper extremity access sites, with good long-term patency and low rates of infection. Our 5-year primary patency of 74% are comparable to other studies documenting good long-term outcomes with transposed femoral vein, and are superior to both hybrid options and lower extremity arteriovenous grafts. The high patency rates make this a suitable option for younger patients needing a more durable access option. Additionally, although wound complications were frequent, infectious complications were not observed in this current study, unlike with grafts. Serious complications such as compartment syndrome and steel may be observed with this procedure. We were careful in the size of the anastomosis and tapering the vein to 4 mm if needed to reduce the risk of this complication. We believe that this, in addition to careful patient selection, reduced the rate of this complication relative to other studies. Thank you to the VESS for the opportunity to speak with you all today. I'll be happy to answer any questions.
Thank you, Dr. Kim. Really good job with your presentation, and really nice presented, and with great outcomes. While we wait for the questions, I have one first. In your algorithm, do you use hero graft at all?
We do make use of hero grafts, although we're somewhat selective and in terms of who we put in hero grafts, just given the issues with long-term patency of the hero grafts. And I think in the past there was actually a study comparing hero grafts and transposed femoral vein fistula, and I think transposed femoral vein fistula did have a longer term primary patency.
So,
Dr. Kim, I can imagine. Oh, sorry. Go ahead, Manuel.
Sorry, go ahead. Sorry.
Well, I think this is interesting, but I can imagine that patient selection for this is really important. And I was wondering if you could just specify if there are really any contraindications that you have, that you would, patients that you think we really would never go down this avenue.
Yes, thanks for the question. You're absolutely right. I think patient selection is incredibly important, especially given the potential complications, including a compartment syndrome. I think in our algorithm for working patients up, we get an ultrasound, arterial and venous, as well as an ABI. Basically any patient with any evidence of any peripheral artery disease is generally excluded. Another important thing is wounds. It's a long incision, and so wound complications, as you saw in our experience, was fairly significant and the most common complication. And the other important thing with getting a venous ultrasound is to not only look for what the outflow is like, but to look for the vein quality. We try to avoid and exclude anyone with any sort of vein thickening or any sort of venous abnormalities, which would potentially cause a problem.
And in terms of anticoagulation, I saw like 16 patients you fully anticoagulated post-op, right? What's your regular algorithm? Do you prefer to anticoagulate or just antiplatelet, or what do you do?
Yeah, for whatever reason, in our patient population, there are a lot of people who are already on some sort of anticoagulation, and we don't standardly put patients on anticoagulation after this procedure, but it just so happened that our patient population had a high percentage of patients on anticoagulation.
Okay.
And I'll ask one more question. If there's anything that's coming from the audience, we can, of course, get that question in too. But how long does it usually take before these patients can have this accessed?
Unfortunately, we didn't look at the exact time until access, but typically, once it all heals, roughly about a month or so.
And your primary and secondary patency is great. I mean, unfortunately, these patients that you exhausted everything, their mortality is high, as you pointed out, like at 3 years and 5 years, it's like, I think 50% mortality. But in terms of secondary interventions, for femoral vein, do you tend to stent or plasty? What was for a stenosis on the vein, what was your preferred secondary intervention?
I believe our preferred interventions were just plasty if possible, and only a secondary stenting if it was like a recalcitrant lesion.
Dr. Kim, you're a fourth-year integrated resident. When you go out into your practice, are you going to be doing this? And if you do, how are you going to kind of start this program somewhere?
I think it's a great option for patients basically who don't have any options. I think as far as starting this, it wouldn't be the first thing I would jump to. But in patients who absolutely have no upper extremity options or really bad central venous stenosis and can only go to the lower extremities, I don't think it's a bad option for them, especially in younger patients who may potentially have a longer lifespan and more benefit from a longer term procedure. I think this is potentially a good option for them.
And it would be interesting if you compare these to your HERO graphs. I mean, it will be a nice study, since you have really good numbers for your femoral veins.
Yeah, that's a great point. Thank you.
We did have one question that came in from Max Wular, who was mentioning that this was a great talk, and then asking for any kind of technical pearls for creation of the fistula that you might have.
I think the main technical pearl is, when we create our anastomosis, we limit it to a 4 millimeter arteriotomy on the artery. I know others have limited it to 5 millimeters or so. I think the largest was 6, but I think a smaller arteriotomy is key in preventing Steele syndrome, which is the feeder complication.
Well, thank you for sharing that and your experience. I think with the answers that you gave, you would absolutely pass the boards. It's not going to be the first thing you're going to do, but it's something to keep in the back of your mind. So we've all learned a lot today from you about this.